Good evening and welcome to this meeting of Adult Social Care and Health Select Committee. I am Councillor Lisa Knight, Chair of the committee, and I will be chairing tonight's meeting. The event is being streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussions taking place. Now I'd like to welcome all those in Committee Room 1 at Kensington Town Hall and everyone watching on YouTube. Before we proceed with the meeting, I would ask members of the committee to please make sure your mobiles are silent and switched off. And I think it would be appropriate for us to start with a 72 seconds silent for those who lost their lives in the Bangkok March. Start with apologies. Apologies for absence have been received from Councillors Mona Ahmed, Stuart Graham, Sam Makoba, and Portia Baxter. And then on to declarations of interest. Does any member have any interest to declare? Next, minutes of the meeting held on the 29th of June 2023. The minutes of the previous meetings have been circulated. Does the committee agree to sign them as a correct record? Agreed. Moving to the first item, which is agenda for Home Care Transformation Programme Update Report. This report provides an update on the progress of the Home Care Transformation Programme. Lead member of Adult Social Care and Health, Councillor Josh Rendell, is to present with Gareth Wall, Director of Integrated Care Commission.
Chair, and thank you for having me at the very first meeting of mine and the committee. I'm really pleased to be here and present to you and be scrutinised by you, be accountable by you for my Ian portfolio. So, really pleased to be here and thank you again for your time this evening. I will leave it to Gareth to speak to operational detail, considering my newbiness. But obviously, I'd like to present the paper about our Home Care Transformation Programme. As you'll see in the report, we have numerous providers that provide our home care services right throughout the north to the south, with various depths that you'll see different parts of the borough with different services. We've got many users that have them, but for the most part, have been very impressed by the service that we have commissioned, although there are a few teething problems with some of the other ones, so I'm sure Gary will touch base on those in due course. And how we kind of scrutinise those and hold those particular services accountable as well. But yeah, just like to happy to take any questions, approaches, or anything on that, and help you out.
Thank you very much. I say a few words of introduction. So, any questions and take your comments. So home care is one of the key services provided and funded by Adult Social Care, along with bed-based accommodation, day services. Home care is where a lot of our funding and effort and focus is placed for a number of reasons. It helps people to remain independent and safe in their own homes. It helps to discharge people safely and quickly from hospital so that they can remain independent in the community. And in most circumstances, it's people's preferred means of receiving care, so getting this right is really important. As you can see in the paper, on average, across Kensington and Chelsea, home care is provided to around 600 residents across the year. We're spending around £6.6 million per year on home care across the range of different organisations. And you often hear, if you're not familiar with home care, the currency of home care is often referred to as hours. And we have hourly rates that are set with different providers. So just a kind of reminder that that's the language that we use, and the measures that we use, like remote home care, that's 270,000 hours a year that we commissioned across the borough to support those 600 residents. The Home Care Transformation Programme is a piece of work that, as you'll note from the report, has been going on for a few years now. And it's had some stops and starts. A big one with the global pandemic, which drew a lot of our attention away for a while. And some to do with changing of style, some to do with some of the challenges that one of our providers in particular has faced. But we are back on track now, and our timescales, as you might note from the report, are for us to issue a procurement strategy in December, and then go out to tender in February of next year to then fully mobilise our new contract in the middle of next year. We have spent some of the time this year in getting this transformation programme back up to speed, doing a number of things, partly revisiting some of our previous assumptions, and that includes some of the shape and size of the geographical patches that are currently used. We have spent a lot of time talking to providers in the market, both those who are currently under contract with us and those who aren't, but might like to work in Kensington and Chelsea, and to understand how the arrangements that we have in place might be adjusted to work best for them and their staff, particularly thinking about workforce. I'll come on to that in a moment, just by way of introduction, because it's a key element and it's a key risk for us in terms of the stability of the workforce, in terms of new recruitment and retention, where people are coming from, how much we're able to pay them, keeping pace with other living wage and beyond. We have also spent a lot of time talking to residents, people who use home care services, their family and home carers too, to understand more from their perspective about what good looks like, what they'd like to see, how they'd like to access home care, because currently the lion's share of home care is arranged and commissioned by authority through contracts, but a reasonable proportion, around 22%, access home care or home care type services through a direct payment, and we have some mechanisms and pilot programs that would enable more people to do that should they choose. We've also done a few things to bring to an end the things that we've been trying to make work for a long time and just haven't. So we took a decision back in the summer of this year to decommission what's called the electronic call monitoring system that we've been using for home care. Most organisations will have this. Do have it, which is effectively the clock in, clock out electronic system that home care workers have when they go into somebody's house. So we might set with the individual as part of their care plan a 45-minute or 1 hour visit in the morning to help them with activities of daily living. When a home care worker arrives, that you via an app on their phones, they're here when they leave, this area have left. And partly that's around oversight management, make sure people are where they ought to be. That's not obviously the only means of quality assurance. But it's also a means where in some systems that can be used as a point of validation for payment. You can speed up payment processes, making things easier for us and the organisations. Those sort of systems are great and big, and they're often littered with a lot of problems. As authorities, we might express a preference for using one. Home care agencies won't only work with one borough, so they might have different systems they use in different places. And home care workers have different apps on different devices. It was getting too complicated for the value that we were getting out of it, so we brought that to an end. We're still receiving data from each of the agencies from their individual systems, and working on our own way of being able to analyse that in one go rather than insisting on individual systems. So that's an illustration of some of the things we've been progressing with in contract, whilst putting together all of the documentation that we hope to go out to tender on at the end of this year and start of next year. The one other thing I just wanted to spend a little bit of time reflecting on is workforce, and it being our key risk. And over the last few years, that risk has increased and we've seen some changes in patterns in terms of stability and recruitment. In particular, the composition of the workforce has changed, where we still have the same proportion of people coming in who are UK based. A slight increase in the number of people in our home care workforce who are within the borough, which sits at around 32%. But we've had a significant drop off in the number of people we're able to recruit from EU countries, where some of the rules and regulations have changed on that basis. That's been offset to a degree by an increase in the number of people coming into home care from non-EU countries, so from other parts of the world. And what we find with that group is cost for the legal process that people have to go through to be able to work on that basis, and then retention, because often we've had examples of successful recruiting staff from Sri Lanka, for example, but in many instances those people are in that home country registered nurses, and once they've been here for a significant period of time, they're able to gain rights, and that might then move on to working care homes and NHS places, so being able to hold on to some of those people is difficult. So retention of the workforce is a challenge. There is a new grant available from government called the Market Sustainability and Improvement Fund Workforce Grant, which we will be spending this year and next with our around developing the workforce, training opportunities, recruitment fairs, some of those costs for bringing people from overseas where necessary. And we're building up a workforce strategy across social care, so not just home care, also staff who work in care homes, staff who work in day services, but a significant focus of that will be on our intentions for the future of how we support our workforce to come into home care services.
And thank you for this report and welcome.
Thank you.
You just thinking about what I wanted to ask you about first, but in terms of challenges and recruitment and retention, which are obviously the main challenges that we're facing here, what can we be doing to make a difference is in terms of the service we're providing this vulnerable group? Are you seeing any trends in terms of our three contracts that we're working with as to why people are maybe not happy in their roles, or whether there's any trends that we can be picking up on, as I'm sure this would have a huge amount of influence on maybe how they're performing their job in the day, and if we can have happy staff who feel appreciated and well paid in their roles, I feel like the service is going to be a different service to the one that maybe we're sort of lacking in areas where we're facing these challenges. And is there any learnings in terms of, you've been working very closely with My Home Care, from that close working that we can be acting on to making a difference in this area?
So there are a number of things that learning from the work that we've done with My Home Care and with other agencies that we think we can do more of to support around that risk of recruitment retention. Pay is obviously a key issue for people in the sector currently and people coming into the sector. We're a London Living Wage paying conditioning organisation, and we check rigorously through viewing cases that applies to staff who are working for our contracted agencies. And our overall rate with agencies, so London Living Wage is at £11.95, our overall rate with our contractual agencies is £21.21 per hour. That's very competitive, we benchmark that across London, and so we're doing quite well on that front, and we will do the work we need to keep pace with London Living Wage and announcements about changes in next year. One of the things that is part of the work in this transformation model that we also think will be looking at the size and shape of the geographical patches, because homework is repetitive work and people are travelling from A to B at times, usually this time of year, although the weather was really nice, usually this time of the year and we're getting towards winter, difficult work. It's lone working, you're right in the dark, sometimes late on estates, and the more that we can make those patches operate in a way that reduces the need for travel time between places, and means that from both a service user, a resident, and a staff's perspective, we're building familiarity with where people are working and who they're working with. That helps. So both staff often say, care workers say the same thing that residents do, that they prefer to work with the same individuals as much as they can as they feel like that relationship and knowledge. There are staff benefits that agencies, including My Home Care, make available that they find attractive for people. That includes things that we do as employers, so things like cycle to work scheme, uniforms, loyalty bonuses, infection training, carer of the month awards, refer a friend scheme is quite a popular one. So you get a bonus if you with somebody who takes up a part of the agency. So some of those staff benefit schemes also would be considered those.
And aside from that, there's not anything to sort of come up as obvious reasons why people say, for example, are moving on or not wanting to work in the area that we can kind of be changing.
It's not something changeable necessarily. It's usually because 2/3 of staff don't live in the borough. They can find work that's closer to home basis and other sort of elaborate. People will do that. That's not just a home care factor. That's true. Social care workforce in general. So no, it's not. There aren't any indications of things that are materially different from the way that agencies that work here, to the way they operate in other boroughs, that we would change, that would shift that. I think. But actually, the one thing that is difficult to do with home care is going back to that point I made at the start, that the currency and the language around home care is our consumption work on the basis of an hourly rate, is being able to make space for home care staff to do other things. So their time is costed. So time to spend liaising with their colleagues, sharing their concerns, sharing their good experiences and practice, building that in from agencies is part of their hourly costed rate, but more of that would be better. And also I think of that in relation in particular to developing work around integrated neighbourhood working and multidisciplinary team working within our kind of place-based integrated care system. It's the home care worker, I think, who is often the person who sees an individual more than anybody else, aside from family and friends might be in the same building, but as a healthcare professional, their hourly rate is sometimes a limitation to that individual being able to participate in discussions about some of these individual care in a way that might be richer. If we're able to do that, it might also be more satisfying to the individual. So that's something that we can find ways to do that.
I think as well, Chair. Obviously, home care has an issue and a challenge with staff retention, but it's not just home care; it's right across adult social care, children's services, schools. As Gareth already says, the borough is a very expensive place to live. That's not in our control as a local authority. It's just the market rate. But as you know, we're building out 600 homes, 300 of which are going to be social work and key worker housing. And the whole point of that is to ensure that people in home care or in other services that are frontline can live and work in the borough, because some of the challenges, of course, the travel time and distance, and not only this, but a whole host of things. I'm sure James afterwards as well was going to speak about his experience with his staffing in his trust as well about that too. So it's a really important question to raise, a really important one to flag. But I think overall we have an agenda here at the council anyway, which is those 300 new social housing, key worker housing, to ensure that we do retain those people in this borough, so they do provide the best service that we can. Because we want to be the best council, and that's the way to do that, I think.
Thank you, Chair.
Far away from
So I've got a few questions. So I guess my first question is, it's been a while since we tendered this. I think I saw 2015. And I guess a lot's changed since then. We've had COVID and actually people's circumstances have just changed. So think we're operating a sort of different world than we were, you know, in 2015. So I'm just interested to know how you're going to think about putting this tender document together to really take account of those changes and the challenges, you know, and more pressures that people have, but also just how to revisit those assumptions that we've always had and how to really change the outcome of this tender so we don't end up with something that we had before. And I know you're very good at that, Gareth, so I really would like to know how you're going to think about that. And just a couple of things from me. On the spot providers, I know we've talked about spot providers before, and I just want to make sure I really understand about them because it doesn't feel very efficient to have 19 providers and all of these staff, I think, are all working for the same agencies. So perhaps if you could talk a little bit about why they're necessary, can we reduce our reliance on them? Because if you've got a provider like My Home Care, I think what I understood was part of the reason why they had the problems they did were financial. So the more business, if you like, you can give them, the more I think it gives them security. And it feels if you've got all of these spot providers, we're taking money away from the kind of key providers. So I just want to make sure I really understand how we use those people and or those spot providers and whether we really need to. And then the other point is when I think that Gerald's raised, and I think you mentioned it about having that one-to-one person and what would we need to do in the tender to get that, because I think it is the one thing that people talk about and building that relationship with them is really key. So that's my starter.
Okay, if I make a start on those then. You're right, it's been a long time since we did a kind of full recommissioning and retender of these contracts. They've been renewed and extended, but I'm glad we're getting to the point now where we'll be able to conclude that work and do something new and more radical with some of them. In terms of what we would want, what we're looking to put into this, that I'll cover some of the substantial change elements. One overarching aspects that we're looking to introduce and that we've been going through some challenging discussions with our procurement colleagues on is the idea of introducing an iterative contract, or a contract that effectively allows us to change things as we learn over time. So rather than having to kind of stop, go out and retender because we've made a substantial change in the way we do something, that we can make relatively broad adjustments to things as we might pilot things throughout the life of the contract. So an example of that would be, we are at the moment undertaking an outcomes which is effectively, again, this is in response to feedback from home care agencies and individuals and our social work teams, is like most authorities, since the Care Act 2014, the approach to making arrangements for home care is largely based on what's described as a time and task model. So an assessment is made of the type of support that someone might benefit from, and then usually that's expressed in terms of hours and number of visits that somebody would have per day. There's a cost model for that goes through a process, and it's quite transactional. And whilst an individual's care plan will talk about the things that somebody's trying to achieve, it's hard to translate that personalisation or that statement of outcome that somebody wants to get to into a contracting model, and how to then cost that. So you've got a price on an outcome rather than a price on an outcome. And so we're experimenting. We're looking at some ways that we might be able to do that, and that would mean that we can still get good value for the work that's being undertaken, but increase satisfaction and build on the good practice of social work teams in terms of their person-centered approach to design care. But that's not in kind of documentation for a contract at the moment. But if we can get to a point where we finally express that, the contract might allow us to do it. Another is the digital platforms that we have. So, as I said, a lot of the majority of arrangements for home care at the moment are undertaken by social work staff and then a brokerage team who put the transaction arrangement in place, and then that's monitored through quality assurance, contract management, compliance oversight, etc., CQC. but there is a facility for individuals to be able to do that themselves via a digital platform that we've been testing this for a while. And again, through the life of the contract, we might be able to discuss these people can access care through the direct payment and managing the transaction, tie themselves and their family doing that on their behalf if they want to. We can obviously do that for them. On the question about the spot and the block arrangement, it's absolutely not ideal. The high proportion of spot providers that we're using at the moment, and partly that's a consequence of the size of geographical patches under the current contract, and under the terms of the current contract, the contracted provider for that geographical area is required under the contract to accept 100% of referrals that come over. So whether that's discharge from hospital, whether that's community care, they are asked to accept all of their referrals under the contract. And it's not practical. Those agencies just don't have the capacity, the speed and flexibility, and in some instances the specialism to be able to do that. So to a degree, changing the size and the shape of those patches might help with that. But also us having secondary providers who were also under contract means that they wouldn't be spot providers, and we could work with them more closely in terms of contract oversight. And then also perhaps having some specialist providers for provision of reablement or provision of home care for people with particular types of support. Is something that we could look forward to that as well, but absolutely aims to reduce reliance on spot provision. One other mechanism to assist with that that's in the proposals is to move from what is currently an entirely activity-based contract. So we can forecast how many likely hours there are to be a year, so a provider can budget and plan for that. But to give more certainty, we can move to a core and flexible, where we give a certain block amount that is paid more regularly, so that there is money available for investment in staff, for investment in training, and then flex on top of that, which allows us to manage this.
Yeah, I'm always impressed when somebody says transformation. So I'm expecting great things from this. But obviously the back office stuff is, well, you might call back office stuff, is crucially important. But as ward councillors, we're often getting the front end of it from residents. And from a resident, from a service user's point of view, what are they, if we go through this, if we commission this and you get the commissioning you want, what are they going to notice that's going to be transformationally different than what they get now?
So, a few things. There's different types of offer depending on their preference. So what I've just described in terms of whether we're making arrangements or they or the family making arrangements themselves, choice in terms of how to do that. If we achieve everything we're hoping to achieve in terms of supporting a stable workforce, then people's number one wish whenever we hold engagement events with residents around home care is around stability of care. So if we can recruit and crucially retain care workers in particular patches of related disease, that's something that I think people see as a concern.
Do you genuinely believe, because that is you're right, that's a key one that comes up time and time again. Do you genuinely feel that we can make some progress on that? Because as long as I've been on the council, that's something that's been an issue we've tried at Chelsea Care. We've done all sorts of stuff to try and address this in the past. And I still get the same comments today as I did 10 years ago or 12 years ago on that issue.
I think the things that we'll be putting into this proposal will increase the likelihood of that happening. But as much as we'll be able to put into the proposal won't solve the global national challenges that we have in the social care workforce. So it will, I believe, will make it better. I don't think it will solve it so that Mrs. Jones will have the same.
And could you just take me through figure 1, the vision? I'm interested in the diagram there and how that illustrates what you're trying to do.
So yes, the individuals at the centre, The blue elements outside are kind of particularly in relation to the activities of people providing and commissioning home care to ensure that the things that the individuals want, so that people express as their aims and outcomes and ambitions for living independently, happily within the community, are reflected in the elements that are in green. So you do things that anybody would might have as their goals or ambitions and things, how they want to live their lives. The blue elements that are a mix of the existing and the new that we want to bring in the new model. There's an iterated version which I can share with the committee, which has more of a workflow approach. How if people have make particular choices or come to the different in a particular way, I think it might move through from one step to another.
So how might a transformed service help me swim more? I'm just trying to get at how wide the service is going to be.
The swim example so there might be two aspects to that. One is that I've spoken about already. One is the outcomes pilot, where rather than us thinking expressly about time and task or the delivery of activities that support some of the activities of daily living, somebody might, as part of their care plan, express ambitions that might be to do with swimming specifically, but might more generally be about health and well-being, benefits of physical activity if they're able to do that, then they have swum before and haven't been able to do it before. And so people delivering home care might be able to help them make trips past the home and accompany them to.
That's why that is a transformation.
Yeah, well, it's because it's not something that a traditional home care agency would do at the moment necessarily. But that's more kind of crossover with a support worker or a personal assistant type role. So the other element that's part of this transform might help that, where if more people are accessing care through a direct payment, usually they might be working with a personal assistant, who may or may not be part of a home care agency. And with a personal assistant, that can be support with activities of daily living, but it can also be other types of activities need some questions.
Good. And I think perhaps one of the things on direct payments is the people we see, and when we see people with problems, generally, you get in an awful muddle with direct payments. And I think sometimes we need to help them more with their direct payments and their accounting for it, how they pay, how long they pay, how much they pay. Because sometimes they get a terrible muddle, and that just exacerbates their nervousness, their tension, their anxiety.
Absolutely agree. The difficulty we've had with increasing the uptake in direct payments is a lot of that people become an employer, they're taking risks of doing that, liability insurance, and it puts people off immediately. One of the things that the digital platform offers is it takes away the detail of that for an individual. And there are two elements on it. One is effectively managing a bank account, so you can see the money that's in your account and how much of it is being spent each week or whatever profile. And then the other is a marketplace, which is connected to the account. So you can say, if I do X amount of spend, I could do that with Sage Care, my home care agency, pick the hours that I book that in, with a particular individual. Or the account can be used, thinking again about this model of beyond kind of traditional home care models, as a payment. So as long as the thing that somebody wants to spend their direct payment on is within the bounds of the care plan that's been agreed with social care, it doesn't necessarily have to be a service or an organisation that's on the marketplace. It could work like a PayPal. So the classic examples might be people using a direct payment for a gym membership. And if it's not a gym membership that's kind of on our books, it doesn't matter. The system allows them to do that quite simply. So this is the transformation here is to make things more simple for people if they want to expand personal choices.
Sounds as though, that's good, but it sounds as though it's making it, for some people, it's going to make it more difficult because once you increase choice, I just the stories I hear of people who get into trouble with direct payment, they can't even manage what we've got now to offer them more choice, without more support and help as a potential to make way. And what you often find with the people we see, you often find that maybe a relative takes on, to start with, takes on the responsibility of managing the direct payment, but they lose interest 3 or 4 or 6 months into it. So the poor person here is left with a problem. And it's just, if we're going to do that more, we need to increase the actual support. Increasing the back office computer system is great, but that doesn't necessarily help the end user.
Understood. We now have a new direct payments team in place that's specifically there to help, as well as the people supporting the system if there are issues with that. And of course, as there is now, there is at a minimum the annual review assessment process with section 40.
I've got a couple of questions then I was going to see if Alex ask them. But my 2 were just firstly on complex needs and what are the challenges for providing greater complex care with increasing rates of conditions like dementia. And then going back to my home care and just having an understanding of when you think that might come in and we would be able to look at as a committee, even if it's just circulated. I don't know if there's been any updates on that, or there's any update.
Just on that one, we've got no white smoke from CQC yet. But as I've reported to the committee previously, all the work that we've done alongside a couple of other boroughs, safeguarding quality assurance teams to take My Home Care through an improvement journey, leaves us reasonably confident with that everything that we've done, that they should be able to make the move out of the required improvement category. But you can then tell what will happen with inspection on the day, on the week. But we will, of course, let you know as soon as we share the report with you when we can. In terms of complex needs, it's an area of challenge, particularly in relation to hospital discharge or when people's care needs escalate. And the challenge is often when we need what gets referred to as double-handed care, so you need 2 care workers to coordinate their visits with somebody several times a day. So it's the coordination of that, as well as it is the cost of that is a difficulty. One of the things that we can do around some of the challenging conditions, if not the challenging logistics, is support teams within home care agencies to specialise more. So there are people who specialise in support with dementia, specialise in supporting more people who have behaviours that challenge. And in those instances, we sometimes pay a higher rate for that type of care. And that therefore allows those agencies to invest more in training and support those conditions.
Thank you.
Okay, thank you. Well, my question's already been answered, which was around direct payments, so thank you for raising that and people needing that support. But just a couple of comments, really. Just pleased to see that and hear there's been so much engagement with residents feeding into this whole process, and the recognition that the consistency of care for residents in the borough is really important, and that's what we actually hear. And just one other comment that I thought that was great, although I know staffing is really challenging, that there's been an increase of staff who are from the borough. That's
any questions from the audience?
I would pick up on Gerard's comment about people getting into a role model about their money and feeling that they don't have the control that the whole system was supposed to deliver.
Anyone else from the committee? No.
I slightly hesitate to say anything, so I have a horrible feeling that this was last tendered when I was the cabinet member. The only question I was going to raise was the timetable looks horribly short to me, particularly given the outstanding works from sort of 4.23 to 4.27 before the tender. And I realise that not all of that has to go live before the first tender, but certainly before the second iteration, which is pretty soon too. Are you confident you're going to make that timetable, and if not, have you got a contingency in place?
I am confident because that timetable has already moved a couple of times. We were originally intending to be able to go to tender in October. The team made a good case about why they wanted to adjust that to spend some more time getting feedback from the market, which means that a lot of the products and documentation are actually already written.
So not all of this outstanding work really is outstanding, probably some of it's half done already.
Outstanding is only being final, but a lot of work is there. Our contingency, if we did need any more time with that timetable shifted, is that the contracts that we have in place at the moment, which are effectively direct awards, allow for that. So they allow for long lead-in mobilisation if we need to make any changes, and if we needed to switch that mobilisation period to more time for the tender, then that's possible.
Thank you very much.
Madam Chair,
Yes.
so what's the process for us now with the tender? Do we get another briefing or where are we?
So, I mean, it's something I wanted to raise as well, and without wanting to, get too involved with all of this, I think all of us are really keen to understand and support the transformation and the change of thinking. So I think we would like to be involved.
We could do it. Really happy to see how the community views and draws, and of course that's we'll ask for that. But we can come back in 6 months if you want with an update with some of the questions that you've raised, especially around Councillor Hargreaves, etc.
6 months, I guess you're going to have made a decision, right?
Yeah, the tender goes live in February.
Up to the committee though. At the committee's discretion on what you'd like us to do. We're in your hands.
What do you think, Gareth? And when is a good time for us to check in with you?
According to the timetable, we're planning to go to the procurement strategy decision late November, early December. If we could provide the committee with a briefing and opportunity to provide any comments on the procurement strategy before we actually go out live to tender.
So we have a meeting on the 30th of November, I think. I don't know if that date would work, but that sounds like a good option. What do you think?
Jones to see if that's possible. If you want to do it outside of the meeting, I'm mindful of your work.
Yeah, the only thing I'll point out to the committee is that you've already committed to 3 substantive papers for the 1st of November, so if it's okay with the lead member of the office, we could perhaps do something outside of the committee and
We
report
can
back.
do we can do that. We can do a written thing, or if you like, we can look at that and do a pre-brief prior to the formal duty start perhaps.
Yeah.
Anything along those lines.
I think that would probably be preferable, and as long as the committee puts in the public domain at a later date, that the
Yeah,
information
that's fine.
was what its views
That's
were.
fine. On our end. We'll do that.
I think that's it.
I mean, I do feel really reassured about some of the ideas that Ian talked about this evening, but I'd really like to see how that plays out when it goes to the tender. And I think there'll be a lot of learnings for other tenders that we're going to be doing, and it's really important just because I think we should be doing stuff differently and learning from some of the challenges that we've had.
Is there any council or borough in the UK that we're looking to, or is anyone getting it totally right, which I'm sure they're not? But we can be looking to see if we can.
There's been a new model introduced in Lewisham recently that we've been looking at. It's quite ambitious and it's quite new, so I'm watching it with interest. But one of the things that they have created more opportunity for them, and what I talked about in terms of the time for home care staff to get together and to share their experiences outside kind of formal training arrangements. They've changed. They don't call it home care. They call it local health and wellbeing workers. They've tried to actually kind of rebrand it in part to find ways to attract new people. So that's been interesting in terms of a launch. There are some other places that have some interesting things to look at, but they're very different in their kind of geographical makeup. So there's not so much read across because they have sparsity issues that travel times.
Yeah, and I think, as Anne said, there's lots of things which are great that you're working on and looking into. And I mean, for me, it's the challenges that we face in this area and what Josh said about building homes and creating benefits that hopefully will attract people and retain them so that we can have the best possible system of home care.
So one other thing that came to mind in terms of other places is overseas there are kind of other models in relation to the delivery of data. But we talked about kind of iterative nature of the contract we might have. We might look to see whether they're appropriate in future. And it's not necessarily home care, not necessarily more nursing, but there's a model in the Netherlands called Virtual, which is kind of a form of virtual monitoring and care provided by a registered nurse over kind of team Zoom screens. And that in some instances works really well. But I suppose I'd say that as an example of being ambitious to look at how other countries do this.
Yeah, definitely.
This is about transformation.
Yeah. And the other than bringing this, what we do outside this committee in terms of bringing it back, but when the my home care stuff recruit to these allocated to the committees in addition to that. I'm sure you would do that anyway. But thank you very much.
Thank you.
Moving on to review of palliative care services in North West London.
Colleagues lurking outside, I'm just subbing them.
Oh, there we go. This report provides an overview of the proposed model of care prior to the launch of the engagement process and seeks the committee's support and opinions on it. We're joined by colleagues from the NHS and West London Integrated Care System. May I ask everyone to introduce themselves and reflect and provide some opening comment on this report.
Yes, hi there. My name's Dr. Andrew Keaton. I'm the Medical Director for West London, which KMC is a part of. So thank you very much for inviting us and we had a chance to debate that. As the Medical Director for West London, I would hope that you were able, well, we certainly support the paper and hope that we're able to convince you to support the paper this evening. We, as the paper describes, we've had a long period of engagement with communities across North West London, including KNC, over the last few years. And one of the reasons it's taken such a long time to get this paper to this stage is because there's been a great deal of co-design going on as well, which I know the team are very proud of too. We're hoping that the paper illustrates to you that we have got the opportunity now with this paper to improve the palliative care services for residents of Kensington and Chelsea. And although we've had a lot of these services in Kensington and Chelsea for some years, what the review has allowed us to do is to extend the hours that the services are available to patients and residents, as well as increase, because it's a North West London piece of work, we've been able to increase the total number of community beds available across North West London, which hopefully will include Kensington, Chelsea and West London too. I know there's probably going to need to be a conversation around Cambridge as well, and I know that there's maybe a difficult conversation to have, but hopefully the paper will illustrate how we are engaging with the community to try and answer those questions and come up with a solution that everyone is able to sign up to. Jane.
Thank you. I'm Jane and I head up the local care programme on the Integrated Care Board. Before I canter on through the rest of the paper, can I introduce some of the other colleagues?
So I'm James Benson, I'm the Chief Executive of Central London Community Healthcare. I'm Jane's Director of Local Care. I'm the Joint Place-Based Chair for the Royal Borough, and I'm the National Delivery Advisor for Virtual Care.
Hi, I'm Navneet Willoughby. I'm the Director of Operations for the Inner Division at CLC, Central London Community Health, which covers Tri-Borough.
And with thanks to my colleagues Michelle and Andrew in the audience who really make this stuff happen, don't get to be in the spotlight. We'll talk a little bit about Cambridge, but if it may, I will set the scene in terms of the model of care and what we've been trying to achieve, because I think that is the main step forward we've taken since we were last here discussing with you. You'll know, a bit like Gareth mentioned earlier, this work started a long time ago and has been paused just a couple of times during the pandemic. And it has also taken a long time to come up with an answer of what we think good looks like for specialist palliative care services delivered in the community. That probably took me by surprise. I didn't expect it to take this long. I thought there was much more national guidance out there that we could build on and take off the shelf. And actually, once we started to look at all the different things that makes up a good service, we found that there are different definitions, there are different specifications. Once you start opening the lid on it, people think of something different. When you say hospice at home, not everyone is needing the same service. What hours should that exist? Is that 24/7? Is that a care service? Is that a clinical service? So every ingredient of the service, we met with a group of residents and clinicians, week in, week out, kicking the tires on that, testing it, coming back and saying, how do we know that's the right thing? How can we evidence that? What needs are we trying to meet? What's our data which supports those needs? So I was not expecting that process to take the time it has, but what it is delivered is a model care document. It's not the paper we've got today, but it's linked in the paper, which is a long document describing the process we've got through to define those ingredients of what good community services look like. I'm not going to keep referencing Gareth, but the three areas Gareth talked about around bedded care, care in the home and day services are absolutely mirrored in the three areas of services we're trying to prioritise in this model. And what we have set out here is that in terms of bedded services, that we have identified there as a set of needs that we are currently not meeting, across most of North West London, but particularly for residents locally. And that is for people who may not need the full gamut of specialist services, a consultant-led service 24/7 and NDT, but for whatever reason can't remain in their own home and don't need to be in hospital. For those people who are not providing an option, and too often they are remaining at home, not feeling that they've got that wraparound support they need, or in hospital when they're not wanting to be in hospital. I don't want to give anyone a suggestion that hospital is not the right choice and the right place for lots of people, but we do know from all of our data that many people don't want to go to hospital, and that is a choice they've got. During our engagement, we have been engaging on some care intensively over the last month. What we've heard very passionately from Kensington and Chelsea residents in particular is around women and men living on their own, how scary that feels as they approach the needy services. And they might not need a hospice, they might not need all that clinical support, but they sure as heck need some really supportive services wrapped around them, and often that being a bedded location. So in terms of bedded services, we're of course saying that we need that specialist care, but we're saying even more there are people who we are not meeting a set of needs from, and that is probably a large people who need that specialist care have a very complex deaths. They are very, whereas a lot of people have more routine experience which can be supported in their own home, in a unit with enhanced skills and support that doesn't need round the clock medical supervision. So that is where we've got to. We've said that the support going into people's homes, both the hospice at home support, which is non-registered clinicians, and also the specialist nursing services that go into people's homes, need to be bolstered in terms of the hours. Pretty good in KNC, but actually we do need to recognise that people's needs don't really slot into a 9 to 5 pattern, and we want to make sure that that 24/7 specialist palliative care advice line is there. What we hear often from residents is they just don't know where to go. They don't know if this is normal. They don't know if it's okay to wait till morning. They don't know if this is something they should be worried about. They don't know which services that they are supported by the right one to contact. So having somebody that can answer those queries 24/7 provides that feeling for people who are held and supported rather than having to navigate a scary world. One of the other things we've heard over the last month is for most people, most residents and carers, this will be the first time they have to do this. It's not something people have got a track record in doing or experience of doing. You encounter this at the worst possible scary time in your life and have to navigate it. So putting in place some of those structures that help you navigate it. People don't want to abrogate that role. They want to be there with their loved ones, but they just want someone standing alongside them to do that. And having that 24/7 advice on it's going to be critical. And then talking about the day services, that may well be day services we think traditionally, but we also pick up the bereavement services there, counselling services, specialist services such as lymphedema, and we have a disparity of what's offered in those services. So we want to make sure that we are able to be really clear about what's on offer and what people should expect, and that's all of our population. So that is what we're saying. Underpinning that is a set of other changes we need to work on that enable that to be that around workforce, having those opportunities to work collectively around some of the workforce challenges, be those around how we knit services together. Your borough is very well served, but it's served by a variety of different service providers. So making sure that those services join up, it doesn't fall to the resident to have to be the navigator, is really critical. And that interface with hospital services just as critical as it is with primary care and of course. So We are at this stage of putting this document out saying this is what we think good looks like. We haven't said in that and deliberately haven't said how we think we should then commission that. We haven't set out where we think these services should be, what structures, who the providers are. Clearly those are really important questions. But as we work through this process, I thought it's really important to have some specific points on the what before we get into the how. Now I know that's frustrating for local residents in this patch because we're really keen to get to the how and well, what does it mean for Pembridge? It was almost so many permutations of what ifs that pinning down the what do we think good looks like for the entirety of the service model felt like the right step so that we can now work up what are our options for doing that? What's the ways that we can do that? What's the pace we can do that over? How quickly we can do this? I don't want to give anyone the impression that these changes are going to happen on the 1st of April. This is going to be a multi-year process to get in place. How do we do that? What's our options around? Is it most important that we get those longer hours in the community and really resource that, or is it most important we get our bedded care provision? How do we work through with you and with communities those options? So we've just, I don't like to say we've just finished a period of engagement because our engagement's always open. We've just finished formally going out and looking for responses on the model of care document. So we're writing up changes to that now, and I'm really, really pleased that there are changes. It was a genuine engagement process. There are things that we are changing, editing, improving, clarifying. So there will be a really clearly updated model of care document, but the core ingredients haven't changed through that engagement. There are some areas that we provide more detail, but it always remain the core ingredients the same. We'll then be coming back out over the next 6 weeks to talk to people in a similar engagement process about what's our different options. What's our criteria for how we select between options? What does it mean in terms of deliverability over what period of time? What does it mean in terms of this being an option which helps us address the workforce challenges? What does it mean? So that will be our next stage of formal engagement. We very much expect then that we will be asked across the consult on this, and we'll be looking to do that in the early new year so that we get that consultation process. We're just very mindful of PERDA lurking in next year and what that might mean in terms of timelines. But I think the real principle for us at every stage of this is to try and be open about where we've got to, what we think it looks like, and how people can input and influence that. I've jumped over the Pembridge section here, but I will jump back to it because clearly people want to know where we stand. At the moment, no decision has been made, and what we are not proposing in our model of care document is any decision on where beds should be. We are saying that we are absolutely convinced, as a model of care group, that we need more beds, but we are not convinced that as a system in North West London there is more specialist beds. What we need are those beds to allow to support more routine needs during those final weeks. Where services are located will get picked up in those options in the next stage, but it will be based on the model of care and the capacity that we have defined in the model of care document. There's a couple of annexes in here because I know there was particular interest from some of the officers in KNC around how we projected demand going forward. One of the things on that we were very concerned about doing was projecting forward based on current activity or historic activity, because you always bake in unmet need doing that. So what we looked at is that forward 10-year population growth, particularly for older adults, but we've done a massive exercise to try and find what's the best way of calculating the unmet need. It's a classic problem, how do you count things that aren't happening? And we've ended up using some of the figures from the Association of Palliative Care Medicine to build in a growth of demand, which isn't just a population demand. We've also looked at travel mapping now in terms of access just to our bedded services, because that's helped us to build a methodology, and we've described that in the document. And we've done that with Pembridge Open and Pembridge Closed, so it shows us split of base. There are clearly a difference for residents in the north of the borough with the unit closed, with the data which isn't obvious to anybody, but the really striking thing doing that mapping was that we got very, very poorly serving North West London people in South and Hayden and Hounslow far west of our patch. And so doing that as an exercise, which we actually did sort of driven by means of that population, is showing us a much bigger challenge that we have for the entirety of the North West London population. And very lastly, we were challenged last time to try and understand better the qualitative experience of people who could have gone to Pembridge and didn't. And we took that as a way as an action, and we've really struggled to do that. We've got a bit of a summary in the paper about why that proved harder to do than we thought. There are several reasons for that. It's very difficult to be surveying people at that time, either residents or their carers. But then also very practically, whilst from a
county perspective, we know who's a Cambridge patient versus a Trinity patient, people with random names. You know, the nursing teams and the people doing the psychological support can't pull out who they have to survey to find out if you'd gone to Cambridge, would it have been different? So we really understood the need to understand the quality of people. We couldn't find a sensitive way to do that exploration. I think it is fair to say that we recognise that for people who are travelling further than they would have done, that would have an impact. And I don't want to take away from that quality, but we haven't found a way to actually capture that from people directly. Let's do that for an action which we gave last time.
I think the other fundamental difference is if we look back where this was when we were sitting here at the point of closure of Cambridge, the ability for us to understand how care would be delivered more consistently in people's homes has altered drastically. At that point, we did not have virtual technology in the ways that we have today. We also did not have point of care testing in the ways that we have today, and I suspect we will have in the future. And also similarly, we had some real discharge issues across the entirety of all of the specialist beds, and we've seen that alter because we're able to support more people at home. And I think everyone in the room probably recognises that during that very difficult period of lockdown, we had far more people wanting to be supported at home, because the reality was admission into a hospice meant that other family members potentially were not going to be present because they could not leave their bubbles. So it transformed the way that care was, and I don't think any of us could have envisaged what that looked like and how we would then move forward with this new model of care.
Thank you. I just wanted to start, and I said this to you, just by welcoming many aspects of this paper. We have the additional opening times, 9 till 5 to 8 till 8 p.m, and the adult community specialist team, and hospice at home, which I think is great. But as I'm sure you can imagine, this paper always brings lots of questions for people at Cambridge, and it's now been 5 years, and I feel like on this committee, particularly with things like the board at the moment, it feels like it's a repetitive wheel of fighting events, but there seems to be not a huge amount of quick movement as to reopening them, and I completely appreciate that. Some people want to be at home, but not all people can be. And I mean, my first question is going to be on the opening of when is Cambridge going to potentially open, but I don't think it's worth asking that, but thank you for the update. And I wanted to start by asking, Monday this week you had a meeting, I think, and also on the 18th of September, and if there's any verbal update there on sort of opportunities or progression conversations, that's something I'd love to hear from you. And then in terms of the recruitment aspect of the care consultant for Pembroke, which I believe has always been a huge aspect of why you're saying it can't reopen because you can't find someone to, whether you're exploring other avenues there, I mean, looking to abroad or looking whether that could be shared with another hospice, or what are we sort of, what can we be looking at doing if it is possible to open it? I don't think, I mean, it scares me in terms of then the consultation, actually how many years this could ever be if you're talking about it maybe one day reopening. Just feels like it's going to turn into a lot of years. And then you talk about, in the report you talk about how hospice sites are to be located with close proximity to private communities. And one thing I think is worth highlighting here is North Kensington and some of those surrounding wards to the Pembridge are some of those private communities in London. And if there were to be beds, it surely makes sense for a unit like that, which is there and ready and yes, lacking the staff. But I mean, I totally appreciate what you're saying about Hounslow and Hillingdon and the geographical side of what you've researched, but that it must be remembered that I mean, Goldbourne Ward is the most deprived in the whole of central London, and that's just on the cusp of the Pembridge. And that's in terms of your travel and adding all these aspects in, they are people who are going to suffer because of the distance they're going to be travelling, and palliative care is an area where if you have a loved one who you're visiting, you don't want to be super far away and spending a lot of money to get there. You want to be able to feel like you're very close by if something happens. Sorry, that was a lot, but
No, absolutely. I'll turn to Navneet in a moment to talk about consultant recruitment and where we are on that, but just in terms of the meetings you talk about, to give everyone else a bit more background. So we had our model of care group who met weekly out of the model of care, and towards the end of that process, we get to written that they said really not want to talk about transition. And one of the things that came up then was we've not really heard what we've done and try, and we don't think you're being as open as you can be to ideas. That was very non-accusatory, but a kind of fair feedback, and we heard that in the meeting. Thought, well, we could say that's not really a model of care. But rather than doing that, we said, fine, let's kind of talk about what we've done. Let's hear your ideas. What haven't we done? What could we do? How are we sharing what we've done? How are we sharing the opportunities and challenges? And so we have had a couple of sessions with largely our model of care group, because people can come on the journey. But as with all of this work, we will be quite got on the website yet, but we will be putting all the outputs of that work, so it's just fully shareable and people describing both what we've done and what the scale of the challenge is. And I think I've said this previously in this forum, or indeed in just we don't have an agenda to make them. What we want is to maximise the opportunity for great services in the care setting. And if we cannot get it open, which is not to do with we can't find a route through, we have money tied up we could be using on our services for the residents. And so I think at some point we have to decide over what timeline we keep trying to open it versus repurposing funding into other services and finding ways to mitigate the travel and transport challenges. Because being in this limbo for another 5 years serves nobody well. And I don't want anyone to take that as I'm advocating for it not to open or for it to open. I think we need a resolution, and we owe it to communities to come to a shared decision on that deliverability. Dragging it on for a lot longer is not going to be the best thing to do. So we have been meeting with people, talking through both with the clinical teams from Cambridge and Navneet's team who manage and direct the unit. What are our opportunities to do things? It was a really great session to have, and one of the things I took from it from the lead consultant there, Samantha, was around some of the ways that the consultant workforce is becoming even harder to find, which is frustrating. The national mood music is that we need to focus on those who are dying, but actually some of the decisions are being made about the qualifications you need and the routes into traineeships have become more constrained. And the second thing that we've had shared and talked a lot about as well, that consultant is, if you like, the key to the door to this. Without a consultant, we can't open the door. But actually, we need 1.7 consultants, other medical staff, and a range of nursing professionals. And so, all of that is not insurmountable, but it is a substantial challenge against a backdrop where teams have moved to work in the community where we have more activity. James pointed about the community. And lastly, we've been having conversations with Imperial around what are the opportunities to work. Those are very early doors conversations. There was no commitments from Imperial there, but there was an interest in opportunities in line with the principles and spirit of the Integrated Care Partnership to work jointly where that might be possible. Again, I don't want anyone to think that that's an easy solution. When services work in that way, there's a risk and opportunity on every side. But what we're trying to do through that process is really make sure we have considered deliverability in the round, and so we can be really clear that those opportunities are being articulated, explored, and really tried to make work. And that links also to what the team are doing currently around consultant recruitment. So Navneet, you want to say a bit more on that?
Yeah, so consultant recruitment is currently underway again. This time we've developed 2 job descriptions for 2 different job plans. So one is a standard community inpatient consultant post, but the second is a hybrid post that looks at both inpatient and community to try and make it as attractive and maybe tap into somebody looking for that kind of mix. So those jobs have been developed, they're with Royal College for approval, and then they will go out to recruitment. And opportunities for recruitment will include certainly looking abroad, certainly being very open in much that way.
And that's, you're talking for the Pembroke Leaf job posts. One thing on that is is surely it's going to be incredibly hard to recruit someone who the future of Cambridge is still unknown. So how are you going to attract someone to that job
So
if they think their job's not going to exist in a year?
So that's one of the key challenges, and that's why this timeline becomes very important moving forward. Because what we don't want is someone to leave a job, come somewhere else for something that is not very tangible. And therefore, I think the move to this model, which I would dutifully remind colleagues, was a model that was put forward, and this document identifies that it was historically discounted at the time of the Pembridge closure, is actually probably best served with a dual recruitment. Because our ability now to go out to recruit something that is more flexible, because in this model, what we're clearly saying is more beds are required. Maybe they're not specialist beds, but if those beds were required, then there would need to be in-reach into those beds. So it's a very different role. And it may allow more flexibility in terms of that recruitment. So we may be more likely to get 2 people who wanted to work part-time rather than a full-time person to that post. I think it also helps us understand what the deliverability of any model would be, because if we find someone, at the end of the Royal College saying yes, and then we go out to recruit, we get someone, it does help us think through, well, what do we need to do next? If we're in the same position as we were before, which is there is no one available, it helps us understand what the likelihood is of delivery of any of these services.
Just really a follow-on question, Jane. I suspect I know what the answer you're going to give me to this, but are we talking months for a decision, a year for a decision? I'm not pinning you down to a day, but give us a feel.
So I would like us to be able to go to consultation in January. In an ideal consultation period, that would be 12 weeks. We can't get 12 weeks before that. So if we were to buy overview and screening decisions to have a slightly shorter consultation process, we could look for a decision immediately after that, so in June. If we are required to do a 12-week decision period, then on 12-week consultation period, then that will push back our ability to get a decision because we'll need to consult. So my view is, given the ongoing engagement, doing the balance of doing a 10.5-week consultation period, is better, so we can get an earlier decision. But that is something we will need to debate with all our representatives.
I was just going to ask one quick one before I pass it over to you guys, and just in terms of the surveys and hearing from those who would have used the Cambridge, who you haven't been able to get that from. I feel that feedback is very crucial to understanding, and I know exactly what you said, why wouldn't you? But is there a sensitive way of doing it so you can actually hear from that audience, maybe working backwards for those from 2018, then to the case of date? I know that people, the last thing you want to do when you've had bereavement is go and speak about your pet. You want to people to go alone, but people now, 5 years on, might be like, you know what, this could be way better for me, and I'd love to help someone else who might have had a better experience. I feel like there is a way of doing it, and it will be so crucial to you in understanding the bigger picture.
Yeah, and so if I step into my local care director role, I think one of the challenges here is asking someone about a service for which they have never received, because the vast majority of people on the books of community services now who are in end of life would never have received inpatient care at Cambridge. So therefore, to ask what the difference between that was compared to what they received in inpatient care is a very difficult one. I think that the nugget here is the travel. What was the impact for you around that travel, which may be answered through really what this document is setting out, which is clearly there need to be other beds and those beds need to be localised. Is what that service looks like would be the more interesting question, which is if something was able to be offered where you had a specialist offer here, but a local offer here with InReach, what's the difference between those two different models?
And we were talking about this on just yesterday morning. In terms of the beds at Cambridge, the share of voluntary cancers in Chelsea and we've done an audit of all our specialist beds, who's in those beds and whether they actually need specialist care or they need it somewhere therapeutic. It was between 20 and 40%. Our specialist beds were there because there wasn't somewhere house, not because they needed that service. So again, I really don't want to come across that application not to open Pembridge. The Pembridge unit, it's a fantastic service. However, we are talking about a really, really small number of KMC residents who are seeking care somewhere else, specialist care somewhere else, because we will have that less complex, supported, consultant supported, but not consultant the whole time care in the area. And if we have to get to a point, because the reason we may get to a point where we have to make a decision that Pembridge can't open as a specialist unit is not because we don't understand what it means for those families travelling to Royal Trinity or travelling across to St John's. We understand how difficult that is. But it doesn't make it any easier to overcome the workforce and deliverability challenges. So we have started with local residents. We have gone through the surveys, the fantastic work that residents have done to really get across the strength of views on Pembridge. We really, really know that. But that in itself is not going to get us 30 nurses. And at some point it's going to need to be that reality of at what point do we weigh up those two things, that keep trying and meanwhile don't invest in other services, versus to recognise that the world has moved on a bit in terms of who needs specialist care, who can be supported in their homes, having a different set of bed capacity. And that might be, and that's the kind of conversation we need to have jointly around the option, because this isn't going to be us sitting one day saying, right, that's it. But we've got to do that jointly. At some point we have to make a decision. And that's going to need to be, it won't be through ignoring in any way the strength of feeling and the challenges on travelling it means for those families. That small number of families impacted.
Can I just finish that point off? I think there's a very interesting point that Jane has gone to. I think there's a difference between understanding the need for a specialist inpatient unit that happens to be in North Kensington and another unit which, as the place-based lead for the Royal Borough, the one place, if this consultation ends with this model of care is what we want, and we were therefore looking, where would we have those beds? Well, my personal preference would be that they are in that patch, because I completely recognise the challenges and the support required for North Kensington. But we have been fixated on it must be a specialist palliative care unit at Pembridge, historic. But I think where we're getting to is maybe we could have a mixed economy, and where those beds are is still just as important, but for a very different reason.
Because I've been a GP in the area for 20 odd years, and I work in the south of the borough, but what was very obvious is that people who were living in north of Kensington didn't get the same support for palliative care as people in other parts of the borough were getting, because of the Pembridge unit. And the Pembridge unit, as I say, could offer very good support to a very small number of people, but there wasn't the support to support GPs and district nurses to look at care as well. And this review of the model of care gives an opportunity to improve the care for everyone, and hopefully increase the number of beds that more people will be able to use.
Just a point of clarification. Not working as a specialist versus generalist beds. The generalist beds are cited where? In generalist hospitals, or?
So I think we've been using enhanced beds. So language is difficult on this, it means different things to different people. What we are, there are different models to how to.
Don't confuse me anymore. I'm a bit of mine.
Sorry, across the country, there is a recognition that there is a need for beds that support people who are less complex. People call all sorts of different things. Some of those might be a floor of a care home, some might be a ward in a community hospital, some might be, they're very rarely on an acute hospital setting, they tend to be in a community setting. So there is, I don't want to jump to where things might be and be held to it, but it's possible that in North Kensington they could be in Pembridge, and there could be a consultant ward round weekly, which is the model where we have this set up in Hillingdon. It isn't a consultant there all the time. But it is, so it is not the same kind of beds, but it is a similar. It could be in other units around about the St Charles patch. We have a number of care homes where we have really excellent relationships and provide rehab services in those care homes. So different ways we could configure services to have a unit with it. It's really important it's not random beds everywhere in our care homes. It has to be a unit where we've got staff with enhanced training and that ability for MDTs and in reach from the specialist teams, a consultant, but not just a consultant, but the sort of wider specialist team. So I don't want anyone to think that I just promise that's going to happen, but the kind of models when we get to options, we'll be looking at each of our boroughs is a distinct unit, housed somewhere sensible, linked to other services, but provided that kind of enhanced service, that it isn't that super specialist complex medical needs. People the criteria for hospice actually for people who meet that criteria is complex medical needs. A lot of people don't have that, but they do have needs, and I think that therapeutic environment which can support those needs in somewhere centrally located, sensibly located, it's something that we just have to have, and I think we will quickly see that having an impact on whether we can deliver on people's choices for where they want to be able to die, because that is also means you can have more of those beds with a lower staffing ratio, so it's a good value solution, so you can have more of it because you don't have that same level of your most scarce, most highly paid, most skilled teams resourcing it. So it's a way that we can reach more people, fundamentally meet a need that we identify through the work that we're doing, and have things which are geographically accessible. That much smaller number of people who do need that specialist medical treatment across North West London, they are likely to continue to have longer distances to travel if that's the way it lands. And that is why I wanted to be really open about options and trade-offs around the entirety of the model, not just Pembridge, whilst recognising how important Pembridge is and the needs of that community and change in travel and transport.
So that's actually really helpful to understand, the difference, because I was struggling with that a bit. When you talk about beds, where are they going to be? I mean, it's quite hard to kind of picture where this could go, and I don't know if you've got places that you're thinking of, that you're looking at. And I have to say, 5 years on, and then another consultation, and another decision by June. I mean, I feel like we're going to be sat here next year still having the same conversation, and meanwhile, life moves on and people have these needs, and where are they going and what are they doing? So I guess it's all about reaching a conclusion now as quickly as possible, and what can we expect that to be and to look like?
So I don't want to suggest exactly where beds will be located here in any boroughs, because I think we have to do that engagement on the options, but I think of where we have space that could be used to make the kind of unit I'm describing is largely in the North Kensington. When we looked at the kind of options we have in our bedded stock across the health, the things that we could flex and use differently to carve out more
And how quickly can something like that happen? Good question.
So that all depends on this recruitment and their ability now to have something on the table that is legitimate. It's a model that's been put forward. I think it gives us a real sense of what resources we would need, and I know the team are working out how do you restart an inpatient service, and what does that look like without necessarily saying it has to be X or Y or there or somewhere else. I think the other component of this is how do you do that and manage potentially opening some of something and waiting for an sort of extended period, because what we might need to do is think through, well, actually is the best option to increase the total working hours, get staff in and then train them in, and then open up a unit should that be what's required. I think there's also something for us, once we land a model that we all agree, that we are collectively in agreement with, even if we are not necessarily all in agreement with, I think it does allow all partners to work in a very different way. So some of the things that are put in this paper, which basically falls the position between all providers to work in partnership together, was not where we were when we closed Pembridge. And therefore I think the relationship of borough-based partnership, the way we work together with the hospices, the acute services, is a very, very different place moving forward, and therefore everyone could start to get some of these resources, and we could actually look to see how you can yourself around should that be what's required.
Councillor, I am really sorry to think it's because having worked on this prior to 300 others when I worked in the borough, I do understand the capacity. However, I also know we've got to make proposal than we had 1, 2,
You know,
3 years
I
ago.
do, I do see that, and I do see the difference between the specialist and the more generalist, and how you can probably have more, better value and more beds available for people. I guess it's just frustrating the time, and you know, I'm just kind of imagining, you know, what are our residents doing at the moment? I mean, I guess they're going to hospital and they're going a long way away, right?
Or they're being supported at a time.
We have more services. So, yeah, I don't think we're not seeing that increase in people going into hospital. We're not seeing any yet, but we are definitely seeing an increase in people supported. And of course, some people are
That might
indeed.
not be their choice.
Well, indeed, and choices change, and you know that. So tracking through that choices is always difficult because we know there is a big trend of people that they are more well wanting to stay at home as things get towards the end. I understand.
But the highlights, sorry, Anne, sorry.
Well, no, I mean, it would be nice to kind of conclude this conversation with some feeling of when we're gonna know.
Decision in June.
Decision.
And the decision, well, a decision in June, but that doesn't mean it opens in June, because then you've still got the recruitment and the refurbishment of whatever it is, wherever you're going to put these beds.
Maybe just quickly follow on, but a huge amount of work's gone into that, and this, I guess, is at some stage you've got to put the stake in the ground, haven't you? Because in 6 months' time it may change again, it may change again, it may, and you've just got to put a stake in the ground at some stage. When is enough consultation enough?
So I think we've got the engagement now in model care that we can conclude to publish that. We've got engagement during November on what are going to be our different options that we would put forward and what are the criteria for how they would get selected. We want to do that so that there is not a sense that this is us having done this quite openly now squirreling away behind a closed door and kind of cooking something up, because that is not the approach we've taken to this. We've tried to be honest with people about what's doable and not give you false promises and hope, but still recognise that no decision is made. So we'll do that engagement in November, and then we think it is likely that we need to do that formal consultation 3 or 4. And then I think that is the engagement on that stage. What I really like though is how, as we go forward into provision, we keep that resident voice just as strong in delivering change. And so one of the things, every time we try to close a survey, I said, no, we're going to keep it open. We've got to be, there is no close to this engagement. It's ongoing. It's just that stage of getting to a document or a point in the process has stopped. But there's been such a benefit from the strength of the residents' voice and the work we're doing. There's fantastic feedback from our nurses who's been in that modern care group, that her practice has changed as a result of sitting week in, week out with residents and hearing that feeling. How do we get that ethos of running our services so we don't just do it when we're working through a difficult modern care business case, we actually keep that front and central. There's so much learning from how we have helped with it has taken. And one of the people in that group has said, actually, we think we made enough decision 6 weeks ago, we can't remember why we did that, we've done that. We come back and kept people with us, and it's taken longer
Just
than
wonder
we
whether people really know what they want. I mean, you don't really know until you're in it, so it's great to consult. Of course, we want our residents to be listened to, but I think people do also look to the professionals and the doctors to. You just don't know, right?
Well, it's
Fortunately,
people
we
who
don't
have
go
that
through
lived
these things.
experience. It's people who have that lived experience who've been in the room. Mostly residents. Some people who are going through the process themselves, is absolute credit to their engagements, but mostly it's residents who have experienced a recent death in the family, and so bring that real experience of what was positive, what was challenging, what would have made a difference, advocating for others in the future. So taking points about how much engagement is enough engagement. We need to move forward and get some change. And I think the model of care is a real fulcrum point of doing that. It puts that mark. How we can do this and move forward to doing it.
Yeah, just a comment. Great to hear all back of the engagement. One thing. So if there was a decision in June, then presumably the recruitment of everybody who's then got to sort of actually make that happen, as we've already heard and we all know, recruitment retention is a really big challenge. Have you been thought about that aspect as well?
Well, I think with particularly with consultant recruitment, it's really important to be really open and transparent about what is happening, because what you want to do is attract people that want to come work in that area. You know, often consultants are recruited because they have colleagues, they're trained for the consultant who's local. You know, it's about keeping eyes on those registrars and who's coming up and stuff. So I think there is an opportunity around making sure that we're open and transparent, that we've got our eyes open, and that's through our consultant colleagues who are very much part of that recruitment process, making sure the job descriptions are there. And also job plans can be amended, so it's about getting the right people, and then it's about making sure that they fit, and being really open about what is it that you're looking for, what kind of role do you want, how can we help you to do that, and that is very much a general retention piece as well.
I suppose opening up a consultant-supported unit as opposed to a consultant-led unit are two very different things. So, you know, I can be a particularly hard taskmaster as Tuesday around, you know, we need to open up another ward. It depends on what that staffing looks like and whether or not you can get those people. I mean, we would be more likely, one would suggest, to get extended scope nurses who could be supported rather than a full suite of 1.7 consultants, junior doctors, full pharmacy and everything. And it's what that looks like. Now that doesn't mean that at some point in the future we might want to do that, but it's about how do you get something quick to market back on the table if that's what is required.
Again, I don't want to be a support you, but back last winter we were looking at our rehab beds. You've opened up our individual area more than 6 weeks.
Yeah.
I didn't open all its beds, it phased its way in, but that was a huge service that's opened up just up the Western in 6 weeks. So I think part of being the options when we talk about phasing is also, we're talking here about open beds, it's really important, but I don't want to ignore the rest of the model. Having services 8 till 8 will make as much difference to a wider number of people. There's more people, far more people supporting the community teams than they are in bed services. So we've also got to think, if we're looking for nurses, where do we put them first? If we're going to be recruiting on a cycle of recruitment, is the best thing to do because we want those beds, or is the best thing to have community teams? And that there's ultimately no right answer on that, but it is about working out phasing over time so that we are maximising the ability to respond to residents' needs. And those needs are as great for more support home as they are for care, as they are for that access to telephone support, advice, and that feeling of being held.
Gerald, do you have anything else? One thing I was going to ask you, but it's just in terms of looking forward to the future, and you will look at to ensure that there's sufficient capacity to meet insufficient demands for the future, as you highlight, an extra 3,000 days will be needed by 2033, and in terms of recruitment and just going forward, how we're preparing for that, because that's
feels big, doesn't it?
yeah, it's big, and I mean we can't even we're struggling to recruit consultants and workforce as it is. How we feel confident about the future.
Very good spots, I think we caught out on that. So this is a 5-year strategy, and our model shows that the capacity we're planning for the fastest for 7 years if we have the right mixture of beds, specialists, and enhanced and advice. But at the 7-year point, I have always said that we need to see this as a 2-year implementation plan, and then we've got some time to bed this in, to start working rapidly for what we do next. Now, what we do next might be we can age right, let's get out of
It's going to take 5 years, so you've got to start before 2 years.
Well, let's assume we don't have a pandemic. But is that a similar process, or actually, we have not done enough historically around children's mental health care? Should we be looking in 2 years once we've got some of this moved forward? Our strategy is about children, that transition, that difficult point for our older teenagers, and how our services. Should we be looking at what we haven't done in this, which is how these services and our universal services are maximising our opportunity? That's something which services do as in a year of normal, but actually is the next strategy, the next stage of this, is it going to be important to be much wider in terms of our scope and that interface with acute? So we will definitely need another stage of this. This doesn't answer every question. Coming out of engagement was a set of services and interventions where people think they might be good for residents, but we couldn't find enough evidence. And there's some pilot work happening around those, be it around support into EDs or care coordination or virtual wards. So a set of things that people are starting to explore that we can both iteratively build in 5 years, but we'll definitely plan for beyond. This will only get us so far, but this will give us a good basis of having the basics right, that we can build that next stage, whichever direction we need to take it, more of the same development, or that children, young people, you know, a lot of work here, which is about supporting people with dementia, but we heard earlier it's a real challenge in terms of the needs of that population.
And quickly, just to add, sorry, the sort of budgeted resources for that, that's also not in the report.
It will be the next stage. And you'll see in the options the comparative kind of budgetary, but we are, you know, as mentioned, there are sets of funding tied up in our system now, which we have committed not to be using for anything else while we work through this process. And so that gives us an opportunity to keep that funding in palliative care, however which is distributed. And of course, there are also benefits where we are using the resource we've got wisely. So if we have people now who are in specialist beds who don't need to be there, that is an opportunity to use resource we've got. We believe this is deliverable within the funding we've got available. This will be over a number of years. A lot of our conversations in the model care group about that right balance of ambition versus deliverability. And so this is not asking for the world, honestly. This is substantial improvement for all of our residents that will give us a really good basis to build on, but it feels doable in terms of workforce recruitment, financial implications, the ability to integrate and join up a variety of services, the ability for tech to support. You know, James made a couple of allusions to some of the digital support it can replace like face-to-face care. We see fantastic work with events. Face-to-face care can be a really great safety net or radar in terms of keeping an eye on. So there are real opportunities for those gains in here, but that will all be the options. Because when we look at options, would be open about the comparative financial resource impact.
When will you have that, just in terms of
November.
Could you circulate it with us?
Yeah. Oh no, well that would be something we're openly engaging on. So
Okay,
everybody will get that sense of options so that we are keeping ties on that and answering questions about is it clear and we move to right.
Any more questions? Anyone in the audience to ask any questions?
Thanks for this.
Thank you very much for coming. Moving on to agenda item 6, suicide prevention in adult males as high-risk group working group. Members will be aware that we reviewed the suicide prevention strategy at our meeting in May. One of the important findings was the high rate of suicide among adult males. So this report is asking the Select Committee to agree to set up the working group to take a look in depth at this issue. The membership will be myself, Councillor Mona Ahmed and Councillor Gerard Hargreaves. We've already involved public health in the scoping document and thank you officers for their contributions. I'm particularly keen as chair to hear from national organisations who are working in this area and hear more about the important work they are doing. We will report back to the Select Committee as the working group progresses. Anna, I don't know if you have anything you want to.
No, I think it's going to be a really good opportunity to delve in a little bit more detail and looking forward to seeing the committees.
Is the committee happy to agree to terms of reference and membership in the report?
Yes, and thank you to Gerard and Alicia for taking that work on.
Moving on to agenda item 7, work programme reports. Report is an update on the work programme and scrutiny activities, setting up reports received in the administrative review and responses to requests for information. Is the committee happy to agree? We did have one amendment actually. Oh no. not taking that outside committee.
Yeah, so I just noted down, I think the home care piece of work will organise some sort of briefing which members will get a sense of what's happening with that piece of procurement and then come back to the committee with the conclusion of what I think of it.
I think they'll be fine, and obviously the report when it's available for My Home Care,
Yeah.
just to be circulated.
Yeah, so when this Care Quality Commission have published that report, and we'll circulate it to the committee as well, with the background about why this is important, why it's an opportunity to read it.
And then I guess, and we haven't got it on here, but we're talking about June for a decision on the palliative care. We should add that to our future work plan.
Yeah, well, I certainly think it's something, I mean, the committee's followed this quite assiduously for the last sort of year and a half, so keep a watching brief on it and then.
Yeah,
absolutely,
I was going to say, because they might have big deadlines, but if
You
we
know,
keep
it's
an eye on
just
it.
taking so long, I feel like at least if we put it on the agenda and they know it's on the agenda and they know they have to come here and explain what they're doing, then it just keeps them on their toes a bit more. And we can't have in June, oh well, we couldn't do the consultation and this and other and now it's slipped again. I just
Well,
feel like
the man Purdah creeped in, we don't know when Purdah is, do we?
well, I
Don't
mean
know
I
when the
guess it's
election
to
is.
do with the mayoral election, isn't it? It's not the general
Yes,
election.
But that's,
So, I mean-
Purdah for the mayoral election is a lot less than a general, isn't it?
Well, it's the NHS to determine, but I imagine it will be the same period of time until
You
the
can't
election
do
period.
political stuff in the
Yeah.
election.
But I think the point is well made, so I think we'll keep a watching brief on it, and they know that you're very interested in it as a committee, and I'm sure that they will come back at your
I
request to
think we
discuss
should
it.
tell them to expect to come back in June. Well, I looked to Mary a little bit here as well. I mean, I feel like this is almost so important that Mary might want to consider it for her committee. I'm just throwing it out there.
We could do, yes.
I mean, it's been such a big issue, and there was just, such a big outcry in the community when these beds closed, and here we are 5 years on, and I feel like, obviously there's been a lot of consultation and good work, and, a lot of what they say makes sense, but it's taken us 5 years to get there. And meanwhile, I feel like, our residents are suffering. So anyway, let's figure out a place to just put it on the record and ask them to come back.
Yeah, this is the obvious place for it to come back to, but, we can't rule out if.
I'm sure it will keep coming back to jobs too. Well, we just only recently had it done, so maybe it won't.
I just think it's important that your committee really has, this is a big priority.
Well, maybe, yes, it's like we pick up at our next meeting, or perhaps you might mention at our next administrative committee.
I should say, well, it is something that if the committee was so minded, you could bring to the attention of the full council as well.
Yeah.
Obviously, the NHS wouldn't attend that meeting, but if you want to report back your conclusions, your minutes, reports, the good work that you've done so far, submit it to full council, that is something that we can facilitate as well.
What does that have? What effect does that have on them, though?
Well, it's not to in so much affect them, it's to allow the full body of membership of the council know this is an important issue that the committee's looked at, done good work, it's reached these conclusions, and then you would have the NHS back to this committee at a later stage. We don't have to decide that now, that's something to consider.
Look, just one other thing that I'd sort of throw out there is, and it's what Lucy said at the beginning of your questioning, is there is a pattern here around the Gordon and these beds and, these establishments closed and they're just kind of, I don't know, they get lost somewhere in the midst of time when no one knows what's sort of happening with them. And it does worry me that there is this pattern with the NHS and their buildings, and I feel like we need to really call them to account on that. And I do trust what they're saying, and I'm sure needs do change and it has to be more flexible, but there is a pattern developing here with these
Certainly
with these
COVID
hospitals.
allows some closures that then will not be reversed. That's certainly.
Anyway,
Okay.
Just another, something different. Where is the right place for us to get an update on COVID and
that's
public health issue and where the future is and how we're geared up as a borough? We keep on hearing of, is this now just going to become another flu and nobody's going to work? What's the future?
Would that be
I think Hannah would be best placed to
Are you done just a
given
briefing
half of
here,
our
just a
committee
briefing
has
here, or?
You could ask the Director of Public Health to do a note to all of this committee.
Yeah.
Yeah.
I mean, why not do it that way? I mean, it probably doesn't need to come to committee at this stage unless you pick
It would be
something up
interesting
from that
to-
note.
Yeah.
While you're there.
Hang on, we have to go. Anyone else got any points on that area? So is the committee happy to agree the report as tabled?
Yes.
And I think we've probably covered any urgent items, so that's sort of in what we were just talking about. So this concludes the meeting, the end of this meeting of the committee. Thank you everyone for your time this evening. Thanks especially Gerard for this evening as well.